I'd now like to introduce Dr. Rich Riker.
Thank you, Dr. Barr. I'd like to thank the ASA, the France Foundation, and Hospira for their support and willingness to put this exciting program together. It's an honor to be on the program with Dr. Murray and Dr. Barr. What I'm going to be talking about today is utilizing validated scales for pain, agitation, and delirium. And as Dr. Barr mentioned in her presentation, as we talk about treating patients, how we assess them using standardized, validated, reliable tools becomes a critical piece of appropriate treatment. What we hope to go through today is to talk in greater detail about these validated scales and talk about how we will implement them and give some examples. In addition, I will spend the last part of my talk emphasizing what I think and what our experience has been is the most challenging of this newer approach to ICU sedation. And that's the concept of light sedation. It's certainly a big change from when I started taking care of patients in the ICU back in the mid-80s. So let's go through things now. When we think about having patients in the ICU, our goals for them include adequate analgesia and pain management, starting sedation only after providing appropriate analgesia, establishing a sedation goal or endpoint and regularly redefining that. Just as no single blood pressure is appropriate for all patients, no single target level of sedation is appropriate for all patients. Using sedation guidelines or protocols, avoiding opiate, benzodiazepine, or propofol withdrawal, and routinely assessing for delirium. These new guidelines that Dr. Barr just got done talking about do more than just update this. They really give us a mechanism and a pathway to follow. Now, one of the most pivotal studies for me was this Thunder 2 project sponsored by the AACN and published by Kathleen Puntillo and her group. And what it did is ask more than 6,000 adult ICU patients to rank the level of pain of 6 common things that are done to patients in the ICU. This was ranked from 0 to 10, where 10 was the higher amount of pain. And as you can see, the winner was not putting in central lines or pulling out sheets or things like that. It was the simple act of turning in bed. This is the thing that patients ranked as the most uncomfortable procedure they remembered from their stay in the ICU. That's certainly a change in my approach to pain for my patients, the routine care things that we do all day long. It may explain why many patients who haven't had surgery and didn't have long bone trauma remember pain and discomfort in their stay in the ICU. So step 1 in sedating a patient is going to be assessing and treating their pain. The guidelines recommend that we routinely assess pain in all ICU patients using self-report, patient self-report, if at all possible, using the numeric rating scale. We know that nurses and physicians and family members are poor surrogates when it comes to estimating the amount of pain that a patient experiences. So again, we come back to the desire for patient self-assessment. How can we do that? We can stop looking at tachycardia and hypertension as surrogates of pain and understand that there are a lot of other reasons besides pain that patients may be tachycardic or hypertensive. This is a scale I took off the internet, but there are many others, and you probably all have them in your ICUs and your hospitals as well. You can see that the NRS goes from 0 to 10, where 0 is no pain, 10 is the worst pain imaginable. There is the Wong-Baker faces, which were developed for pediatric patients, but have since been applied to adults as well. I like to say that on rounds, I want to keep my residents at about a Wong-Baker 6. In addition, there are some translations there that are sometimes helpful as well. What do we do about patients who we try to wake up and we try to ask them about their pain, but for whatever reason, they just can't communicate that to us? Assuming that they have intact motor function and behavior that we can monitor, there are now two validated scales. One's called the BPS and the other is the CPOT. Now the CPOT was developed, and as you can see, there are 3 or 4 criteria on the left-hand side: facial expression, body movements, muscle tension, and then either compliance with the ventilator if it's an intubated patient, or vocalization if they're extubated. And then within each of those categories, our patients get scored 0 to 2. So the lowest score would be 0 in all 4 categories. The highest would be 2 in all 4 categories, or a score of 8. The BPS is a very similar scoring system, looking at facial expression, upper limb position, and compliance with ventilation. And within each category, patients get scored 1 to 4. Now, in addition to having these tools available, where again, patient self-report using the NRS is our first choice, and only if we can't utilize that do we go to the BPS or the CPOT. Payan, who developed the BPS, published a very provocative study. And what they did is they looked at a number of ICUs and they had patient data. And they went into that data and asked the question, on ICU day 2, was the presence or absence of pain documented? Not were you having pain, yes or no, but was the presence or absence documented? And you can see in this graph that if that was documented, patients less frequently had a sedative on board, and that included less frequent midazolam and just missed statistical significance for less frequent propofol. How might that be? Well, it may be that if we're trying to keep our patients awake enough to assess their level of pain, we can actually use less sedation and perhaps no sedation. In addition, the documentation of the presence or absence of pain was associated with a non-statistically significant reduction in ICU mortality, but dramatically significant reductions in ICU length of stay, mechanical ventilation, and a trend toward a reduction in VAP. So again, our efforts to try to document and assess the level of pain in our patients may lead to changes in care that may lead to improvements in outcome. You've heard of this no sedation study that came to us from Norway, and this was another important approach that we have incorporated in these guidelines, and that's how important pain is and using analgesia first in our approach. This no sedation study was actually an analgesia first approach. All the patients were receiving morphine, either 2.5 or 5 milligrams as needed, independent of which arm in the study they were in. You can see in this study that there was a dramatic reduction in the duration of ventilation, ICU length of stay, and hospital length of stay as a result of this approach. So our PAD guidelines, we want to maintain a light level of sedation because it's associated with improved clinical outcomes. We recommend that sedative medications be titrated to maintain a light rather than a deep level of sedation, and we recommend either daily sedation interruption or a light target level of sedation. Now, as Dr. Barr mentioned, we recommend is the word for a very strong recommendation. In order to be able to target a light level of sedation, you need to know what that is. So we're going to spend a little bit of time now talking about the sedation scales. These subjective tools are based on observable behavior. They have proven inter-rater reliability and validity, and they've been shown to show appropriate changes over time. A few caveats of when they may not be appropriate. Certainly during neuromuscular blockade, you cannot use these because the patients may be wide awake but immobile. In addition, we've gained some information that suggests that when patients are deeply sedated, these tools may not be reliable, and I'll spend a little bit of time showing you some graphics about that. Now, the first of these subjective assessment tools was developed by Mike Ramsay back in 1974. He really was years ahead of his time, as he always is. And this was a scale where there were 6 different levels, going from anxious or agitated all the way down to unresponsiveness. In 1994, John Hansen-Flaschen from the University of Pennsylvania wrote an editorial in Critical Care Medicine that really, I think, set the tone for where we've come. And they highlighted that although the Ramsay scale was out there and was widely used, there were a lot of things we had to do better when we developed new sedation scales. So I think Hansen-Flaschen's editorial really pushed us in the direction we've since come. We developed the sedation agitation scale first in 1994, which was a 7-level scale with 0 in the middle and +3 and -3. And that evolved to what's the current version of the sedation agitation scale, which remains a 7-level scale, 3 levels of agitation, 2 of awake or light sedation, and 2 of deeper sedation. This was similar to the MASS, which was published at about the same time. And then the Richmond Agitation Sedation Scale developed by Kurt Sessler, or the RASS, which has a few more choices, 4 different levels of agitation, 3 of awake or light sedation, and 3 of deep sedation. Both the SAS and the RASS have behavioral descriptors that accompany them. One thing of caution, though, that I want to bring to your attention, note that in my description, RASS is a -2 is the lowest level for light sedation. And this is the approach that's been adopted by the guidelines group. Some people have thought that a RASS of -3 is equivalent to light sedation. That's a patient who will open their eyes to stimulation but not make eye contact. And we tested this in our ICU and found that about 24% of these patients, if you use the CREST definition of wakefulness, that's very similar to what Dr. Barr mentioned earlier, 24% of those patients were not awake. And indeed, the confidence intervals with the small numbers we studied may have gone as high as 38%. This becomes important when we start to look at delirium and responses to delirium assessments as far as the patient really awake enough to be able to do the testing. All of these scales have been tested for reliability and shown to be reliable. This is one of the things that led to the recommendations. So again, the guidelines will recommend that the RASS and the SAS are the most valid and reliable tools for assessing quality and depth of sedation in ICU patients. I want to move into the issue of delirium now. As Dr. Barr mentioned, this is the area that there has been an enormous amount of research done since the last guidelines. We know that it's very common, affecting perhaps more than 50% of patients in the ICU, associated with a higher risk of death, not just in the ICU, but even after discharge from the hospital. A much longer period of ventilation, or conversely, a reduction in the number of ventilator-free days, a 4-fold higher frequency of device removal, and a 9-fold higher incidence of cognitive impairment at hospital discharge. This is shocking to us when we first started seeing this data. I learned, as many of you did, that delirium is a disorder that is temporary. It comes and it goes, it fluctuates, but it is not a permanent thing like dementia. We're learning now that that may not be the case, that in many of our patients in the ICU, they never return to their cognitive baselines. So therefore, anything we can do to try to intervene and reduce the incidence of delirium may do more than save lives or shorten time on the ventilator. It may allow people to get back to their cognitive baseline, something we all value. This is a recent study looking at cardiac surgical patients that was published in the New England Journal. The darker line you see are the patients who did not have delirium. The gray line are those who did. And some of the important things are that the patients who had lower mini-mental status exams were at greater risk to develop delirium. They had a more significant cognitive impairment and had a much reduced incidence of returning to that baseline by the time they left the hospital, and that extended out to 3 months and 6 months in this study. So again, showing us yet another study that confirms the long-term effects of delirium. We tend to think of delirium as representing only that agitated patient, but in many studies that have looked at this, it turns out that actually hypoactive, psychomotor retardation presentation of delirium is a more common thing, and it may be associated with a worse outcome. This is some data from Joanna Skrobic and her group from Montreal that looked at patients who did or did not have delirium or drug-induced coma, what we consider deep levels of sedation for more than 24 hours consecutively. This is a survival curve, and you can see that the group that did the best were those who had neither delirium or coma. The group in the middle had delirium with or without coma, and the group that did the worst was the group that had coma without delirium. So I think it really emphasizes that we need to pay attention to delirium, but we also need to pay attention to our use of sedatives and the amount of time we keep patients in coma. The PAD guidelines recommend routine monitoring of delirium with the CAM-ICU or the ICDSC, and recommend that coma is an independent risk factor for delirium, that benzodiazepines may be a risk factor for delirium, and that we don't have enough data yet to really tell us whether or not propofol is a risk factor for delirium. This is some data from Wes Ely's group at Vanderbilt, where they looked at a large number of medical ICU patients and identified that the dose of delirium is strongly associated with the risk of developing delirium. Now, the CAM-ICU is, again, a Wes Ely developed tool from Vanderbilt, and it's a relatively easy and quick tool to do. It takes about 20 or 30 seconds. In order to be considered delirious, you have to have feature 1, an acute change in your mental status or a fluctuating mental status. Number 2 is inattention, which can be easily checked by just having the patient squeeze your hand when you say the letter A, but not any other letter. So you need both features 1 and 2, and then either feature 3, cognitive changes, or feature 4, an altered level of consciousness. The presence of features 1 and 2, and then either 3 or 4, that's delirium. I want to point out the importance of altered mental status giving you feature 1 and feature 4. You need to be very careful and make sure that your patient is truly awake enough to do this assessment. And there's a growing body of literature now that suggests that if patients are tested with the CAM-ICU before they're fully awake, there may be an inflated incidence in the diagnosis of delirium. So be careful, make sure they're awake. The other tool that is recommended by the guidelines committee is the ICU Delirium Screening Checklist. This is an 8-feature item. If you have 4 or more of these features present during any single nursing shift, they don't have to be present at the same time, that's delirium. If you have only 1, 2, or 3 of them, that's not full-blown delirium, nor is it normal, right? It's not normal to have hallucinations or inattention. So that gets called subsyndromal delirium. And in this data from Ioannis Grobek's group, you can see that if you look at ICU mortality, length of stay, or severity of illness, this subsyndromal group really falls between those with normal neurofeatures and delirium. So it may be a future target group for intervention. I want to talk a little bit now about some of the objective monitors of sedation. We talked about the subjective ones, and you all know of the BIS or the SedLine or the Narcotrend. There are a number of different EEG devices that are out there. The BIS is one that's really received most of the publications and comes in various different forms. And this is some data we've really got experience with the SAS and the BIS, so I want to use these and exemplify something for you. Many of the papers that have compared these objective monitors of sedation have concluded that they don't agree with SAS, RASS, Ramsay, any of the typical subjective scales, and therefore conclude that they're not reliable. But I don't think that's the right interpretation. And this is from some data we have collected from actual subjects. If you start at a SAS of 4, that's awake and calm, with a BIS of 95, as you get increasingly sedated, as we give you more and more drug, your SAS will go to 3 with a BIS of 83. And as I keep giving you more propofol or more midazolam or more lorazepam, eventually we'll get down to a SAS of 1. And let's say that's at a BIS of 56. If I keep giving you more and more drug, you can't go any lower than a SAS of 1 or a Ramsay of 6 or a RASS of -5. Once you get down that low, I keep giving you more drug, your BIS is going to continue to go down. So things aren't linear at that end. And that's where subjective scores fail. Let's go back now to 95 and have that patient now start to get agitated. As they get agitated, they go to a SAS of 5. Their BIS may go up to 98. Then as they go to a SAS of 6 and a SAS of 7, now their BIS can't go any higher than 100. Again, here, the relationship is nonlinear. So this is the area where the EEG-based scoring systems fail. So the concept of linearity between these two doesn't make any sense to me, and if we test them that way, we're not going to find agreement. So the guidelines from the committee recommend that these objective measures should not be used as the primary method to monitor patients if they're not comatose and not paralyzed. In that situation, we have a reliable exam that we can follow, and we should use a subjective tool. The guidelines do not go so far as to recommend that they strongly be utilized when you're comatose, because we don't have enough data to say that. But they do recommend that they should be utilized in patients who are receiving neuromuscular blocking drugs. There's good data to suggest that recall in the ICU of paralysis may be as high as 18% in studies that have performed this. So if you're going to paralyze your patient in the ICU, use these tools. Lastly, we'll talk about applying these tools in the ICU with a target of lighter sedation. Now, this is one study, but there are many that have been published that show the same thing. How often do we target a level of sedation and then put our patient at that level? This study suggests that 15% of the time we have our patients at target, 30% of the time, 30% of the time they're at target, 15% of the time they're under-sedated. They're more agitated than we would want them to be. 54% of the time we over-sedate our patients. And it's clear why that may happen. Drugs accumulate, our patients have organ dysfunction. There are a lot of different reasons why the kinetics and the dynamics and our own practice tendencies end up with over-sedated patients. We used to think that was not a big deal. And I'm going to skip this graph only because it isn't especially applicable. We used to think this was not a big deal, but now as we have a number of randomized studies that document the impact of lighter levels of sedation and the dramatic improvements in outcome associated with lighter levels of sedation, it's worth the effort to get our colleagues and ourselves and our nurses and our families comfortable with the idea of lighter levels of sedation. So let's go through that information. The first study that was published that looked at this issue was by Brooke et al. From Washington University, and they randomized about 300 patients to either a protocol-directed sedation, which was where the nurses were empowered to titrate up and down on their drugs and to downgrade their drugs, to down-dose their drugs automatically, or the existing protocol that existed in their hospital at the time, no change in drug dose without a physician order. So this study was published in '99, actually conducted in '97 and '98, and that was pretty much the standard at the time. What they found was that the protocol group had a similar incidence of continuous infusion sedation at about 40%, but for a much shorter period of time, 3.5 days compared to 5.6. The time on mechanical ventilation was half as long, 55 hours versus 117. ICU length of stay was 2 days shorter. Hospital length of stay was almost 6 days shorter. And the incidence of tracheostomy was half. So really a very strong signal. Efforts to improve lighter levels of sedation and increase the amount of time at lighter levels of sedation made a big difference. John Kress, as Dr. Barr already mentioned, had the daily wake-up study that was published in 2000. Again, patients are randomized to either routine care or a daily wake-up where drug was turned off and kept off until the patients were awake and then restarted at half the dose. Again, what they showed is a shorter time on the ventilator, 4.9 days compared to 7.3, shorter ICU time, and 1/3 the diagnostic testing, LP, EEG, CT scan, to answer the question, why won't my patient wake up? Have they had a stroke? If you look at the percentage of days that patients were awake even for a few minutes, in the protocol group with daily wake-up, it was 86% of the days. In the standard care group, it was 9%. That meant that 91% of the days patients were comatose for the entire day. So again, lighter level of sedation. Interestingly, the dramatic reduction in drug doses was with midazolam, not so much a reduction in propofol with its much quicker action. This was a pilot study by Geeta Mehta and her group from the University of Toronto. And what they did is they compared the two approaches we just talked about, the Brook titration approach versus the CREST daily wake-up and sedation interruption approach. And what they found in this study was, number one, you could do it. It was a viable study to do. A trend towards maybe a little bit less time on the ventilator with protocolized approaches like Brook used. And both groups were targeted to a SAS of 3 to 4. And they have now completed their larger study. It was presented at the ATS last year. And it looks, in brief, like it doesn't matter which approach you use, that the protocol may be as good as the daily sedation interruption. We're eagerly awaiting this to be published so we can learn more of the details. This is probably the most convincing study. This was a randomized study performed at the University of Washington by Treggieri, and what they did is they randomized about 130 adults to either light sedation with a modified Ramsay definition of that, or to deep sedation. Both groups got morphine for analgesia, and midazolam was the sedative used in this study. Now, this is a bit of a complex table, so I'm just going to show you that what they have here is day 1, 2, 3, 4, 5, 6, 7, and basically they were able to accomplish their sedation targets. But the more impressive finding from this study is the drug doses. The green lines are the group randomized to light sedation. The red lines are the group randomized to deep sedation. The dotted lines are the morphine doses. The solid lines are the midazolam doses. And if you look at this, you can see that they started about the same place, but for the group randomized to light sedation, the daily doses stay about the same over the first week, whereas to keep a patient deeply sedated, look what happens to those drug doses. They're up in excess of 100 milligrams a day of morphine and midazolam by the end of a week. The effect of this on patients we can only imagine, but it may have something to do with the long-term negative consequences of deep sedation. More importantly than just the drug dosing differences, they showed that at 4-week follow-up for the survivors of the study, 6% of the deep sedation patients could not complete a simple questionnaire. None of the patients in the light sedation group had that problem. The deep sedation group had higher PTSD scores, had a third of them could not remember being in the ICU, and when they did, 18% of the time they had more disturbing memories, probably because they had no factual memories of being in the ICU. All they had were hallucinations and delusional memories. At ICU discharge, the deep sedation group had spent twice as much time on the ventilator, an extra day and a half in the ICU, and had a 4-fold greater incidence of depression. So pretty significant outcomes associated with better outcomes with light sedation. So to summarize, our target for assessing pain in patients in the ICU would be self-report using the numeric rating scale from 0 to 10. If unable to do that, use one of the behavioral studies scales, either the BPS or the CPOT. Sedation assessment with the SAS or the RASS. Delirium assessment with the CAM ICU or the ICDSC. That EEG-based devices may be appropriate during neuromuscular blockade, potentially in comatose patients, and monitoring potential seizure patients, and that a lighter sedation level appears to improve outcome. Thank you very much.